going to say good morning, because I don't want Cecile to feel bad. This is our plan for this afternoon, and we're reporting out on a talk time of 20 minutes. This is our team for RPIW number 49, and I have to say it is an awesome team. It couldn't have been put together any better. We had all the skills that we needed on this project. So for this project, our overall title was Create and Implement a Standard Care Process for Substance-Related Disorder Diagnostic Group in Adult Mental Health Inpatient Unit from admission to ready for discharge. And that is a mouthful. And it was a job to start with. Looking at some of the data when we started out, the average length of stay was 7.9 days, but the thing that we found out was that clients with the substance use disorder, they actually weren't staying that long. So it was a bit of a challenge. And what we found is we were looking that 65% of the admissions were triggering for substance use, and only 48% of those were having referrals done to addiction services. And there was also a significant delay in the referrals to addiction services. So when we got looking at our theme a little bit more, we started to refine that as well. And what we decided was that every client with a substance-related disorder diagnosis deserves and will receive addictions-related intervention while admitted to the mental health inpatient unit. Lots of paper switching. So this is our pre-Kaizen value stream map, and you can see that there was lots of lots of areas for improvement. We did base it on the average length of stay of the 7.9 days. One key area that we did accomplish a lot on was this first wait period here from the time the client was admitted till the time that the client was referred to addiction services. And you'll hear more about that. This is our post-Kaizen value stream map, and you can see we addressed many of the starbursts that were on there. We did add some daily addictions programming for the clients as well. This is our target progress sheet, and I'm not going to go through all of them, but just a few things where we did do some work. 5S, we worked on space, inventory, and evaluation. We looked at the walking distances for a smoking cart that was being used, which was fairly significant gain for staff. Our defects that we looked at through this, one was clients that were triggering for substance use, but there was no referral being done, or there was a delay in discharge due to the clients not having been seen by addiction services. There was no group programming at all for substance use clients, and ADS referrals were missing information pretty much 100% of the time. Our TAC time, we took and looked at that based on our admissions and the ADS referrals, which is addiction services. And what we found was that our TAC time, that beat that we should be working towards, is that we should be having a referral sent to addiction services one every 12 hours. Can you slide that down just a little bit? This here is our standard work combination sheet, and I thought it was kind of important to look at the pre and post because it is a bit confusing. But what we're looking at, the red line is our TAC time of every 12 hours. And initially when we looked at the timings of stuff going on, our TAC time at 12 hours was hitting in that first waste period that we were seeing between the time that clients were triggering on admission to the actual time when they were being referred to addiction services. So we were not meeting that TAC time. After some of the improvement work that we did, we eliminated that first wait of 48 hours by having them referred right on admission. And so you can see that we were easily meeting our TAC time of a referral going every 12 hours. This is our waste wheel, and we combined that onto one page as well. But our top one, you can see that there's a number of wastes, and there were some in all areas. We had 21 wastes overall identified. And post project, we've seen a 47% improvement in the waste that we're seeing, and I think as I was sitting thinking, a couple of the key areas that we're really struggling with that didn't apply to this RPIW with some of that space inventory or the working area for staff down there, or even programming for clients. So.
Hello, my name is Debbie Creedy. I'm the programming nurse on the mental health inpatient unit, and I'm going to talk a little bit about the addictions referrals. We have a couple of ideas summary sheets here that summed up some of the ideas. The first idea summary sheet identifies that there was really no standard process over who made the referrals and when they were made, and the proposed solution on it was to create some work standards around that. And the second idea summary sheet showed that even when a client is identified as having an addictions referral, they didn't always get one. So the solution to that was to add the referral to the admission package. I'm going to explain these stats. Really pretty close to Kaizen. The pink lines are the ones where the clients that were identified as having addictions issues. And pre-Kaizen, you can see 48% of the clients were referred on admission. And so there was 52% that weren't. And then post-Kaizen, you can see the improvement there. Some of the improvements made to the process overall was clarifying the information needed on the referral. There was some information added to the database to visually remind the nurse. Sorry.
You're good. You're good.
Keep breathing. Okay. They added some stuff to the database to remind the nurse to send the referral. And the referral itself is now in the admission package. And it creates some beautiful work standards to go along with that.
Good job.
I know CPR.
Good afternoon, everyone. My name is Alexis Poulin. I'm a patient care coordinator on the mental health inpatient unit. So what I'll be talking about was the new referral process for receiving the referrals and the follow through. So the idea sheet here just identifies that that we had before the improvement. There was no standardized work, and after the improvement, that all of the referrals to addiction services would be done upon admission, that there would be a process for that. So the referral form to addiction services was added to the admission package to ensure that each individual who triggers for a substance use disorder has a referral completed upon admission. The goal of this is to eliminate referrals being missed and or not completed at all. Once the referral is completed, it is then faxed to the addiction services counselors. The faxing process was simplified and mistake-proofed by programming the number into the fax machine. So the referral from there is then placed in a referral binder. This referral binder was created during this RPIW. Once the referral is received by the addiction services counselor, they will then come to the inpatient unit and review the referral binder to determine if there are any additional referrals they have not yet received. This is done with the goal of reducing patient wait time. So once this is completed, the addiction services counselor will begin their assessment via chart review and staff consultation to determine client readiness. And from there, work standards were completed and processes were trialed to ensure proper information flow. So we did a multi-skills training schedule where we were able to train and practice the processes that we've put in place, and it looks like it's going to be a success.
Hello, my name is Donna Kaminsky. I'm the clinical nurse educator for the mental health units. We had an idea sheet that was given to us that was showing us problems with communication, our communication process throughout. And to help with this information flow, we developed the following changes. On the 24-hour nursing flow sheet, there was insufficient information that was communicated. We improved upon this by adding a referral completed in faxed area, a waiting to be seen area, seen by the addiction services worker, and the date. We increased the information sharing and process from our addictions workers to the inpatient unit. Previously there was a case note that was done and left on the client's file. The new process involves the case note and the screening tool information that will be emailed to the unit clerk, who then would print off and place it on the client's file. A standard work was created for this. There are many instances of short-term admissions, examples like over the weekend, where the person is discharged before the addiction service worker can see them. To improve access to resources, we added on to the bridging form, which is our discharge form, an area under the addiction services area for appointments, an emergent after-hour services available from Monday to Friday with the contact name and numbers. In addition to that, we also added the mental health and addictions walk-in services information packet to all the admission files for given out the discharge.
Okay, hello everybody. My name is Maria Lloyd, and I'm one of the addictions counselors that provides services down in the mental health inpatient unit. So this is an idea summary sheet that we decided to try and make some changes. One of the problems identified on the unit is that there are clients that have numerous admissions, and we've attempted to meet with them and they refuse services. And when they refuse services from addiction services, there's really no other option for them while they're in the unit to obtain information. So what we did was we implemented a standard addiction information program that is created already. We have 5 days worth of addictions information, and it'll be provided once daily from Monday to Friday. And the reason that we chose Monday to Friday was because of the short admission. If we were to choose, only a couple of times during the week, odds are there's going to be numerous clients that are not going to receive that information. And having the goal was also to provide another opportunity for engagement through another process. Some people are not always comfortable with one-to-one, so a group process gives them another opportunity. This week we were able to trial 2 of the addiction groups. In the first group there were 28 admissions to the unit, and 13 of those admissions attended the group. The second group we had 6 people attend, and by this time we had already implemented the binder referral process that was talked about earlier. And so 4 of the 6 people in our addictions group had a referral waiting for them in the binder and had not yet been seen by addiction services. So that was 4 people that were able to have an intervention rate a lot quicker than waiting for the addiction services worker to get there. And I guess the other thing I wanted to share was in our very first group, the very first day that we tried our group, as a counselor or a therapist, people know that it's really hard to measure success. Like, it's very hard to know that you're, impacting a client's life. But we had a client that attended our group, and he had numerous previous admissions to the unit. Addiction services had attempted to meet with him, had offered him services numerous times in the past, and he always refused. He was never interested, but he attended the group. He participated, he shared information, he asked questions, he even stayed and completed a survey. So that, to me, was a success. Out of this whole process, that one client that we've met with so many times in the past, he was willing to receive services and engage in the process. It was amazing. And then we ran into him in the unit the next day. He was being discharged. He saw me, came over, he wanted to introduce me to his support person that was there to pick him up. We've never had an interaction like that with him ever in the past. So when I think of this program, this process, that is exactly what we wanted to do, was to reach clients. So I'm really grateful to have been a part of this, and it's been amazing.
Hello, my name is Tyler Sylvester, and I'm an RPN on the mental health inpatient unit. So I was in charge of client involvement, and one of the issues we looked at was clients lacked an opportunity to be a part of their care planning. So our goal was to involve clients in care planning and to increase cohesion between goals, that of the provider and that of the client. So our first way to resolve this is we implemented a bedside communication board, which is utilized in other areas of the hospital and other health regions. So 2 examples were trials just to see if there would be a go or not on our unit, and both patients were absolutely ecstatic about it. One patient even wanted to rip it off the wall and show it to Dr. Backer. One of the 2 trials that the patient felt like prior to the implementation of this board, he felt like he wasn't really having that relationship with the nurse. He felt largely ignored. And post-implementation, he felt like he was actually with the caregiver on the goal. They were on the same page and they were able to work towards them. And a work standard was created regarding this somewhere. Here it is. Just to make sure that this is happening at the shift onset for all nurses. And then our next idea was to develop a board pertaining to their care team so that people knew who they had access to and what services were available to them during their stay. As you can see, our pre-Kaizen, there was a board full of stats that weren't exactly applicable to patients, and they even asked patients what these stats meant to them, and they said nothing. We don't know what that means. So we revamped it up with a quick trip to Michael's. And then our goal was to visually represent all members involved in their care and schedule of daily activities to promote involvement in all RT and all aspects of their care. So, post-Kaizen, it's a one-stop shop for everything. It's a Monday to Thursday schedule for RT activities, and the clients loved it, and actually we had a group of clients help us establish it, which was quite awesome, actually. And then, the positive feedback from that was that they appreciated the agenda of the week, the weekly schedule, as opposed to the daily schedule that was on there before. It was more visually appealing to capture more of an audience, and clients helped enjoy creating it, of course. And a work standard was created to ensure that that process is carried out through each shift. And we also created a skills training schedule just to help with the nurses to kind of implement these new changes, because change isn't always accepted in the easiest way, so hopefully this will prevent that.
Hi, my name is Jackie Postman, and I'm co-lead of this RPIW, and I come from Sunrise Health Region. So we did have an amazing team, and if we were given the resources, we would have built you a new unit. But instead, we settled for a 5S project, and we looked at the dictation multi/purpose room, which really serves many functions on a very cramped for space unit. So the top picture shows some of the items we were able to relocate were some lab specimens which were in this room, and we located them closer to where nurses need them and use them. The top picture also shows in this room a smoking cart that's used for residents. Every 2 hours, nurses come and take this cart and hand out supplies to clients and inpatients. We were able to open space in that room by removing that closer to where it's used. Our spaghetti diagram also shows that by removing that, not only did we create more space in that room for other uses, we reduced the distance that a nurse travels every 2 hours significantly through the day by locating that cart closer to the door where they go and smoke. We also were able to, with the help of maintenance, get some books put on the walls so that it removes some of the clutter from that room. And you can see our door is visible. So the top picture shows our pre-Kaizen. There were a lot of pieces of equipment in there and multiple pieces of purses, personal items, and those kinds of things. We made a space. We were able to get rid of everything, but we did make a space for some of those personal items, and we removed as much as we could that wasn't applicable to that room. We also identified several items that we were able to red tag and remove from the space completely. We also developed a audit standard work standard, to keep that space organized. And we also developed an audit metric for Adam and his team to keep up the work. So this brings us to our newspaper, and I'm glad to say that we were able to do a lot of work during this RPIW in a week, and we were able to close off a lot of the items, which will make Adam and Corey very happy. One of the things that I'd like to focus on is, we were able to develop several work standards related to this RPIW, and because we were able to do that, some of the follow-on work that will occur will be the multi-skills training. Of course, in an RPIW, you can't reach all the staff, especially in a unit with 24/7, so that will be some ongoing work. And two other items would be resourcing of a 5-day-a-week addictions group. We were able to trial it 2 days in a row, but we also know that that will be some work that the team will need to figure out who's going to do those addictions groups on an ongoing basis, because it is a very patient value-added intervention. And finally, that space, the 5S space, we created from the nursing perspective, feedback that we got, there's a lot more space, potentially ability to put another desk or a dictation table in that space. So we did create some opportunity to explore for that in the future. Next is our target progress report result sheet. Just a couple of things. By the 5S, we addressed space, and we increased the space where we removed the cart by 100%. We took out seven kind of items. We were able to take out all but 2. So we left only 2 items in that space with a 71% increase. And also just on our lead time, we didn't address the admission or length of stay, but what we did address, and we improved by 100%, was referrals on average, because they were being missed, was about 2 days by the time they were caught and referred for the first time. By doing it and moving that up to the admission package, we improved that 100% with no wait. The other piece that we'll highlight is our defects, and the triggers for substance abuse that weren't getting the referral. We were at a 53% defect rate, and we were able to get that to only 22%, so only a very few being missed, and we think we can get that to 100. Addictions related group, we had nothing. We now have a group that is easy to run and hopefully easy to resource, so that's 100%. And our referral forms were always missing information, from dates to information that the addictions counselors needed. And we did a scan after we implemented some of our work standards, and it was 100% all information was on the referral form. So that was a great improvement. And then just again with our 5S, we went from a score of 1.3 to a score of 2.4. And we would have liked to get the purses out of that room, but we're going to leave that to Adam.
But we didn't put it on.
And Adam doesn't carry a purse.
Whoops. Hi, I'm Claudia Driscoll, and I'm here for this week as a patient family representative. And all I can say is, wow, the success that has taken place with our team in a very short period of time as to being able to get to the client with substance issues and helping them on their way to discharge. The whole area revolves around communication. And the first step is that the first person I meet is the nurse who asks me a lot of questions, but I know from her that there's going to be a referral to the addiction worker, and that person is going to come and see me, and help me get well. Now, all those referrals are now centralized in a binder, which is easy access for the addiction worker. And the person who's going to determine whether I'm ready to be seen or not by the addiction worker is the addiction worker, ready to see. And then the addiction worker, which did not exist before, has a great time with the client, writes up an assessment, gives the results. All of that goes to the patient chart on the ward, which can be used by all disciplines. We looked at the person who said, no, I do not want your help, I don't want service, I'm leaving, get me out of here. And what we finally determined is, yes, we can plant a seed. And that seed is planted, and the person is included now with the room boards, the board on the main lobby, which is your care team, the one-on-one relationship with whether it's a nurse and certainly with the addiction worker, and the discharge pamphlet, which was developed to help people get back to care if they need it. The other group were the people that were admitted on Fridays, discharged Monday, had no time to be seen by an addiction worker. What happens to them? And once again, with the nurse's help and others on the team that day when they go home, some of that will be discussed, plus a pamphlet which guides them to services in the community, city, rural, and northern. What we decided that yes, from all just in a few days, 3 days perhaps, the referral rate to the addiction worker has increased markedly. And that has to be kept in mind because the need is greater, it is going to continue to grow, and how are we going to handle it with the resources we have? What I and all our team looked at as well is on discharge, we haven't talked about family, community resources. What are we going to do out there to help the client with substance issues? Be it city, rural, northern. We did not address those questions. A lot of thank yous have to be given at this moment, and I just want to show you the list of people that have been involved in looking at the client who needs help with substance issues. I'm not going to name them one at one. I'm just going to give you a time to look at that list and think how many people were involved to look at one issue. The client with addiction issues. So in closing, I just want to thank all my teammates who welcomed me very graciously. And I learned a lot from everybody that was involved. And just a comment to everyone, yes, I as the client, I'm in good hands. I know you're there to help.